Maybe we'll just give people a couple of moments to sign in. Oh, there's about 64 people there, so give people just one more minute, then we can start. Well, it's 8:32, and we have over 70 people on the line, so I think we'll get started. Good morning, everyone. Welcome to this week's Pediatric Grand Rounds. I'm delighted to facilitate this Grand Rounds, and this Grand Rounds is fully virtual this morning, so hopefully none of you tried to get into one of the W rooms on site, or if you did, you ended up back in your office. We have a great presentation this morning. We have a trifecta of presenters. Before I introduce them, I'll do our land acknowledgement. Ottawa is built on unceded Algonquin Anishinaabe territory. The peoples of the Algonquin Anishinaabe Nation have lived on this territory for millennia. We honor them in this land. Their culture and presence have nurtured and continue to nurture this land. CHEO also honors all First Nations, Inuit, and Métis peoples and their valuable past, present, and future contributions to this land. And this morning, you're going to have the pleasure of hearing what happens when geneticists and genetic counselors and informatics people and AI all come together and what kinds of problems they can solve. So this morning, you'll hear from Dr. Sarah Sawyer, who's a clinical geneticist at CHEO, who has a focus on rare diseases and cancer genetics. Her research focuses translating genomic technologies to clinical care to improve outcomes for patients. And she is also an associate professor in the Department of Pediatrics at the University of Ottawa. Alexandre White-Brown is a clinical genetic counselor at CHEO and works with the prenatal diagnosis team. He holds the position of research associate at the CHEO Research Institute and focuses on the coordination and implementation of the Think Rare project, which you're going to hear about today. And Ivan Terekhov is an analytics professional who's been working with the EMR data for the past 10 years in a variety of different roles spanning data conversion, business intelligence, and data architecture. He's currently the Director of Research Informatics, AI, and Technology at the CHEO Research Institute and oversees the data warehouse, our AI cluster, and EPIC research applications teams. So welcome, Sarah, Alexandra, and Ivan. The title of their presentation, Harnessing AI for the Early Identification of Patients with Undiagnosed Rare Genetic Diseases. Over to you.
Great. Thanks, Jason, and to the RI for giving us the opportunity to speak. And it's very timely because we'll be, well, you'll see, but we'll have a best practice advisory that's coming up soon. So we need to tell you all about it. Slide. So I'll give you a second here to read the objectives. But basically, we want you to understand the why and the how we created the Think Rare algorithm. And we're going to talk about how it's going to impact your department and what we want you to do to help us out. And then we'll talk about a few things that'll make the algorithm even better and what we're planning to do with it in the future. So there's 4 parts to the talk. We'll talk about the background and some AI infrastructure. Then we'll talk about the clinical impact that the retrospective studies have shown that when we've tested out the Think Rare algorithm already. And then the application going forward and the BPA, or best practice advisory, that we're preparing to launch. And then plans for the future national, international expansion. So rare diseases are collectively common, although individually rare. So the numbers show that about 1 in 50 Canadians are living with a rare disease. And many of these people face a very long diagnostic odyssey. Sometimes, over the lifetime, 20, 40 years. And there's lots of reasons for that. But one of the big reasons is minimal training that other physicians, other than geneticists, have in the area of rare disease. And so unless there's one person who's looking at all facets of a medical presentation, it can be hard to identify that there is, in fact, a rare disease that's likely to be occurring in this patient. Other problems that are hard to get access to geneticists. Testing is difficult, expensive. There's not a lot of standard criteria for diagnosis. So although there's many problems with in the rare disease world trying to figure out and diagnose these patients, we're focusing today on trying to improve training or awareness of rare disease in all clinicians. So the WHO had a recommendation on their rare disease platform that we need to equip frontline providers with better tools to make a diagnosis of rare disease in patients and to be able to refer these patients to the proper place, which in this case is genetics. And probably doesn't need to be said, but when you diagnose a patient with a rare disease, you first of all give them a name, a community, prognostic information, recurrence risks, and then can identify other family members who are also at risk. So the diagnosis really is a very important step in the journey of these patients through the healthcare system. So to do this, we approached Ivan and his team with our problem and asked them to figure out for us how we could do this through our EMR, how to identify patients who are very likely to have a rare disease. And so I'm going to turn this over to Ivan now for his part of the talk and how they developed this rules-based system to figure out which patients had a complex disorder. Over to you, Ivan.
Thanks, Sarah. So just for a little bit of background on how this project came together, since about 2018, the Research Institute has been investing in kind of ensuring that our EMR data in Epic is available for research. A lot of the initial work was really supported by CHEO Foundation funding. So all of this to say that with the proper protocol, RAB oversight, some funding, you are able to interrogate all the data that goes into Epic during routine clinical care. So all of this data that you see entered in the system is going to be overnight loaded into a large database. Alex, please advance. That is available for research projects. Next slide, please. So today, our informatics team actually has grown to include not only the data experts, but AI and data science experts, folks that are well-versed in the front end of Epic as well, and really helping you conduct your research studies in Epic or in using Epic data and using some of the advanced algorithms that you hear about in the news. We've also equipped them, next slide, please, with a high-performance computing cluster. So this allows for us to experiment with neural networks, with large language models, and other techniques that are kind of top of the line. It's really not, though, about trying to insert AI into everything. The team is there to support investigator-driven projects where an algorithm might help with a particular problem, like in the case today. So if you think you have an idea for a project, please get in touch. We'd love to hear about it and see how we can support the work. So I think really the success to this project, as Sarah said, was the multidisciplinary composition of the team. We had our clinical experts with the clinical genetic counselors and geneticists providing the context and the subject matter expertise, and our data experts that know all about the Epic database and algorithms. And we come together to create something that works. So we actually started working on this in the beginning of the pandemic. This took a long time to do. All of this was hours and hours of work. We spent a lot of time developing the algorithm on retrospective data, and that's where you will see some of the older patients coming in from in the upcoming slides. We also, after developing the algorithm, we went on to do a silent trial. So it was on in the background, sending alerts to the research team, and it ran daily on over 260,000 charts. And that brings us to the full launch this year. So all in all, we spent about over 600 hours of data team time and 500 hours of chart review to develop this tool. So lots and lots of work went into making this. Our final algorithm is next. Yep. Our final algorithm is first excluding patients based on parameters such as age, existing issues that could potentially trigger the algorithm. So if they have a presentation that's already known, but might require a lot of complex care, we exclude those. We're also not looking for patients that are already known to genetics or have an abnormal genetics test result in their chart. So after we filter the patients out, we're looking for patients where they have a combination of specific diagnoses that are split into categories and multiple visits to specific specialties at CHEO. I'm going to hand it back to Sarah, who's going to talk about some of our findings.
So the clinical impact, I think, surprised all of us. The numbers are still small, granted, but to date, our diagnostic rate is 70%. And we compare that to the best test that we had, which is exome sequencing, and the diagnostic rate of that is 30%. So right from the start here, from our first retrospective study, the clinical impact has been enormous for the patients that we've pulled from this algorithm. And I'll give you some more details about that. Next slide, Alex. Thanks. So this is a 17-year-old male here who presented to clinic, and as you can see, he's got dysmorphic facies. And so I say he presented to clinic, he was flagged by the algorithm, and we reached out suggesting that he was flagged through Think Rare and may have a rare genetic disorder. And so his physician then referred him. And so some of you may have seen some of those staff messages that we've been sending out for the past year or two. And he was flagged because he had multi-system involvement. So his heart was involved. He had ASD and VSD. He had intellectual disability, had been seen by ophthalmology, had hyperopia and strabismus, as well as laryngomalacia. So there's 4 different developmental or multi-systems involved there. So he was a classic for Think Rare. The more systems you have involved, the more likely you are to have a genetic condition. And so we did our testing for him, thanks. And we were doing, at this time, chromosomal microarrays first as a first line before doing exome sequencing. And in this guy here, we found his answer based on array. And so he had a 17p11 deletion. And this deletion encompassed a whole lot of genes and 2 specific disease genes that were in the Mendelian inheritance in man catalog. And so his first diagnosis was Smith-Magenis syndrome. And so this was a great fit for his facial features, his dysmorphic features, his intellectual disability, his heart involvement, and the eyes. And so that he was solved from that perspective, from the reason that we picked him up. But there's a secondary finding in him, which was a Brit-Hogg-Dubé diagnosis. And so this is a cancer predisposition syndrome. The individuals can get lumps on their skin and have an increased risk for renal cell carcinoma. So he immediately had a change in his care plan. He was sent to other specialties, talked about seizure awareness, and then was put on cancer surveillance at the same time. And then we were also able to check to see if any of the family members were also affected. So this had a pretty huge impact on him at his age of 17. One of the other patients we saw was a 17-year-old who was going to engineering at Carleton next year. And although these aren't his pictures, we don't have permission to show him. These are pictures of other individuals with the same condition look like. So he had some minor dysmorphic features, but was very highly intelligent and high functioning. However, his medical history was again very multi-system involvement with tetralogy of Fallot, been seen by ophthalmology, had high myopia, ENT, again, conductive hearing loss, and was at the 1st percentile for height. He had some interesting MSK findings with avascular necrosis of the hip bone, as well as fibrocartilaginous coalition of the feet bilaterally, for which he had a few surgeries and misaligned jaws. So when we looked at this, we didn't have an answer based on that. So we did our test, and we started again with a microarray, which was normal. And then he went straight to Genome-Wide Sequencing Ontario, or GSO, for exome sequencing. And a new change in CHD4 was identified. And this causes a condition called Sifrim-Hitz-Weiss syndrome. So this is an exceedingly rare disorder that most individuals with this condition have intellectual disability, but our guy does not. But the MSK features, the cardiac features, the short stature, and the physical features of his face were a perfect fit for this. And so in this gentleman, this was really pretty life-changing for him. He and his family had always wondered why he had such a complex medical history, and no one had ever tied it together for him. He was also, going off to university and starting to think about having kids of his own one day and wondering what the chances were that this would happen in them. And so we were able to give him very clear recurrence risks, and we have options of prenatal testing if he wanted to as well. In this case, there was also prognostic information for him where there's a chance of hypogonadotrophic hypogonadism. So he had a referral to endocrinology as well. And this picture here shows his real life journey that we've put together, that it took us 17 years to figure out what he had. Now, the gene wasn't identified until 2016, so fair enough, there'd be some journey. But this chart here that Alex put together shows how many cardiovascular clinic visits he's had throughout his lifespan: orthopedics, hepatology, plastic surgery, he's been through the healthcare system so much and yet was never flagged for having a rare genetic disorder. So we're hoping that our Think Rare algorithm can change this experience for patients going forward. Excuse me. And this is a quote from his parents that they gave us afterwards, and I'll just let you read it. Okay, Alex. And then the third patient I'm going to talk about is this 9-year-old here with, again, dysmorphic features. And Think Rare algorithm identified him, again, because of the multi-system involvement. So he had congenital hydrocephalus and had a shunt, so was seen by neurosurgery. He also had diagnosis of mild intellectual disability. And so those are, the three things right there that would make him eligible for genetic testing. And because we're suspicious he's got a rare genetic disorder. And then interestingly, in this case, there's a family history of similar intellectual disability as well as physical features. And so it seemed like it was quite possible that was ever running through this patient here was actually inherited from a parent. And there would be implications for management for multiple family members if we could solve this child. And so he had a normal microarray, and then exome sequencing identified a pathogenic variant in a gene called PHIP. And this is diagnostic for Chung-Jansen syndrome. And so this is pretty huge again for this family. They'd been having a lot of difficulties with the school system. The school hadn't been providing many supports. They weren't sure why things were somewhat harder for him and his mother, in fact, as well. And so this really clarified and gave them a place to call home. They found a community in the Chung-Jansen syndrome community. And I'll flip to the next slide. And so for some families, a diagnostic changes a lot of things because they now have a name. And so they can go to the internet. There's individuals who are also affected. And finding this community and realizing that there's others just like them can be really powerful and impactful for a lot of families, as it was for this family. And so they came back and had a lot of questions for us and were very engaged with us and did a little video for us as well. So Alex, I'll flip over and we'll show you
So
here.
at the appointment, we were sat in a little room where Anthony was sitting between mommy and I, and they told us that it was Chung-Jansen syndrome, which both of us looked at each other and like, we don't know what that is.
What is it?
So what is it? And since Anthony is more French than English, he listened in but was not paying so much attention because he was playing with mommy's cell phone. And out of the blue, he just looked up and said, "Oh, that's why I don't understand everything."
Yeah.
And he started to cry. And that's when mommy and daddy became emotional. Less questions, less stress, less blaming ourselves.
And just now daddy can go right now in the special school and all that, and not going like 3-4 school.
So yeah, it would have put a lot less stress on Anthony. This research actually brought kind of a peace in our house. A little bit of blood answered many questions.
And so we couldn't have said it better ourselves. And so we're hoping to have that diagnostic odyssey end for lots of families. And so this started to catch the attention of the news. So it's sort of the first time that AI had been used to find children with undiagnosed rare diseases. And so this was local news and then made national news. And there's a little segment on CTV national news as well that was done on this project here. So it really is one of the first of its kind AI in rare disease. And we're hoping to expand it even further going forward. And so I told you that we had 8 diagnoses. And so these are a list of the other 5 here. And they're all, some of them, recognizable. Kabuki, Soto's, probably people have heard of. A few really rare ones, Malan and Char syndrome. And what's important to realize is that for all of these children, their medical management had changed. There was screening guidelines to put in place, prognostic information for the families, recurrence risks as well. So by providing families with this diagnosis, it really did change a lot of things. It was important for them. And so overall, we've seen 23 patients in the Rapid Access Genomics Clinic. And so patients who have identified with Think Rare don't wait long. They wait another, possibly 4 weeks to be seen by us. We've got dedicated space and resources to see these patients quickly. 13 so far have results. And so that 9 out of 13 is at 70% diagnostic rate, which is just, more than double of what the general exome diagnostic sequencing rate is. So the algorithm is working exceptionally well at picking out children who truly do have rare genetic diseases. And we still have 8 who have pending results, and 2 we saw that didn't have testing. One, excuse me, the sibling was already undergoing testing, and the other one, they weren't actually eligible. The information was wrong in the chart. All right, and I'll turn it over to Alex now, who will talk about this best practice advisory that you're going to start seeing that we hope you'll action.
Yeah, so I have the pleasure now of talking about our Think Rare Best Practice Advisory. And as Dr. Sawyer mentioned at the beginning, it really is timely right now having this presentation today, as this BPA will be coming to CHEO Epic in March of 2025. So as Ivan had mentioned previously, we kind of split Think Rare project into 3 phases. We had our retrospective proof of concept study, which looked back to 2018 to 2024. More to just show the proof of that this concept works, that an algorithm like this will be able to identify the right patients. Then what we wanted to do is see, could a BPA do what we want it to do? And before having it be provider facing, we wanted to do it silently so that we could have identified patients notified to us on the research team before we turn it into a clinical BPA that will notify providers directly. So on top of our goal of running the algorithm as an independent clinical BPA, we also wanted to really focus on provider education and knowledge translation, starting with our presentation today. And also over the next 2 years, we really want to evaluate the performance of the algorithm, really focusing on provider experience and areas for improvement. So for providers that are receiving the BPA and who are going to be actioning this BPA, you may receive questionnaires, or you may have us reach out just to get a better understanding of your experience with the Think Rare BPA, so that we can continue to make modifications and continue to make it better and the experience good for providers. So building a BPA is actually a lot harder and takes a lot more time and work than I personally realize. What we did to put the BPA together is we met as the entire Think Rare team for an entire day to go through all of the different things that need to be considered when creating a BPA. And the first thing that we discussed is who will see this BPA, this best practice advisory. And we decided that it would be best for all CHEO physicians and residents to see this BPA. And the reason we made that decision is because we figured that this would focus on providers who can make referrals. We would avoid overwhelming other providers with extra BPA pop-ups. And physicians and residents are most likely to be the patient's most responsible providers. In terms of how the BPA will function, the BPA will act as a pop-up when the provider opens an identified patient's chart. So essentially how this clinical BPA will work is it will run on a daily basis. And if a patient becomes eligible based on the information in their chart, so maybe a new encounter with a certain specialty or a new diagnosis code on their chart, once they become eligible, the next time that a provider, namely a physician or a resident, goes into that patient's chart, there will be a pop-up that goes through why the patient was identified, how to make an order to a referral to genetics, and I'll show in the next slide an example of what it will look like. The BPA will remain in the patient's chart and or pop up again until it's actioned. And there will be 4 different action items on the BPA. So you can place a Think Rare specific order to genetics. You can say that the patient maybe doesn't meet criteria, family declined, or perhaps other, where you can provide specific feedback if one of the top 3 options don't fit. So this is an example of what the Think Rare BPA will look like. First of all, you can notice here that this is the reason for the BPA. So the patient has been flagged as a potential candidate for a referral to CHEO Genetics. Next, this first little paragraph here is an explanation of the BPA as well as GSO criteria, so Genome Sequencing Ontario criteria, to help guide the decision. And there's actually a link down here that will link to a PDF that has patient eligibility criteria for clinical genome-wide sequencing that will have all the information that you need to help guide your decision to make the referral or not. So one thing that's very important to keep in mind is that we know that that it will still take the provider reviewing the patient's chart prior to making an order for a referral to genetics. So it's important to have that information there and available to help guide your decision. This little paragraph here, this little bullet point, will tell you how to get back to the BPA if you open this link. So we'll just give you information on that. And then this paragraph here is maybe one of the most important ones on the BPA. And this is an explanation of why the patient was flagged and potential reasons for false identification. So we know that rare genetic diseases can be mimicked by other explanations. For example, extreme prematurity, HIE, perhaps they have resolved issues or already have a known diagnosis that was made maybe not in our EPIC system here at CHEO. That's why, excuse me, that's why it's still important to review your patient's chart when you see this BPA to understand if your patient may be a good candidate for a referral to genetics. The BPA just functions as that pop-up a flag to review your patient's chart and make a referral if you as the provider feel that it's appropriate. So this button here will be an order. So that will open an AM referral to genetics with a specific ThinkRare referral type. This will prompt an orders only encounter or open order if already in an encounter. So that's if you click the order button. And if you click the do not order, there will be this decision tree here. So if they do not meet criteria, the BPA will disappear only for that provider. So if you choose that the patient does not meet criteria, the BPA will disappear for you, but it will still be there for other providers of the patient that go into the chart. If you choose that the family or patient declines, this will cause the BPA to disappear for everyone, so all providers. And if you choose other or feedback, this will allow to send us direct feedback or another explanation as to why you do not want to refer the patient to genetics. So once these patients are identified and referred to our genetics clinic, there will be a specific referral type, so our booking staff know that they are ThinkRare patients. We plan to have monthly available clinic spots for patients that are being identified by the ThinkRare algorithm and the ThinkRare BPA. And the patients will be seen by genetic counselor and geneticist, so likely myself, another genetic counselor, and Dr. Sawyer, within 90 days of referral, and will be offered genome-wide sequencing if they're eligible. So the workflow of the clinical BPA, just to kind of give a general understanding of how this will work. So the ThinkRare algorithm runs daily and triggers BPA alerts and identified patients' charts. If the provider refers the patient to genetics, they will be seen in genetics. If the provider does not refer their patient to genetics and they're a patient that would actually be an appropriately identified patient, so not a false identification like HIE, we will actually still be doing a monthly review, so a back-end review by myself and another genetic counselor to make sure that we're catching any missed patients. So we know that not all patients that are flagged that are going to be appropriately identified patients will be referred for many, many different reasons. And that's why we've actually had the approval from CHEO Privacy and Ethics to still do a monthly review of patients who are being identified to make sure that if a patient is an appropriate patient for referral to genetics, that we can notify the MRP or their PCP through a fax and recommend a referral directly. And then, as you can see, that arrow comes right back up to the patient being seen in genetics. And the goal is just to make sure that no patients are being missed that are appropriately selected patients. So one of the really important things that we want to stress today is that our algorithm, and any algorithm really, is only as good as the data, the available data. So if there's incomplete data in a chart, missing data, outdated data, or inaccurate data, so for example, if a provider closes a patient encounter and the patient had an episode of syncope, but they put in seizures instead, this really affects how good the algorithm can function, because the algorithm can't understand that the diagnosis code that was put in for seizures is actually not representative of what the patient had. So it's really important that when we're putting data in the chart, namely the diagnosis codes and the encounters, that we're making sure that that data is complete, that it's not missing, that it's updated, and that it's accurate. And the importance of accurate clinical documentation can really be boiled down to 5 specific points. So we want to really stress using accurate and appropriate diagnosis codes when closing an encounter, as the example I mentioned before. Updating the problem list for both new and resolved issues whenever possible. Uploading results into the appropriate lab order. So sometimes we've seen in our review of the retrospective patients that a genetic testing result, for example, may appear in the patient's media tab, and it has not been properly uploaded into the lab order in the labs tab. It's really important also to pay attention when opening a new encounter. So the way that our algorithm works is it will look for patients that have been seen in 2 different departments 2 or more times. So if one of those times is an encounter that's been opened by accident, our algorithm will still pick that patient up. So it's important to pay attention when opening a new encounter, and then closing encounters within a reasonable time as well. Our national and international expansion is kind of our future plans for Think Rare, and we've been in talks with a lot of Canadian institutions who are looking to use something similar to Think Rare. So we kind of have 3 plans for expansion over the next couple of years. Our first goal is a national expansion for institutions that already have Epic. So Alberta Health Services is a really good candidate for this because they have an Epic server that functions for their entire province. And then Sick Kids as well would be a good candidate. We know that we can't just pick our algorithm up, place it down in another institution and expect it to work exactly the same. So we know that it will require a lot of work and fine tuning for it to work properly in other institutions, but it definitely is our next step once we have the clinical BPA firing in our own Epic EMR. We also want to investigate and look into institutions without the Epic EMR. So for example, BC Children's Hospital has shown a lot of interest and they have an EMR called Cerner. And then lastly, we've actually already had a lot of international interest from Australia, a couple of countries in Europe, as well as the USA. So we'll look to, perhaps in the next 3 to 5 years, have international expansion of the algorithm as well. Oops, I'm just gonna go back. So I just want to send out a big acknowledgement to our entire team. As Ivan mentioned at the beginning, this entire project is not possible without everybody on this list, as well as Dr. Sawyer and Ivan as well. It really takes a large team, and we're very fortunate at CHEO to have a well-resourced team that makes this possible. Dr. Boycott, Caitlin Chisholm, Grace Ade, Nicholas Mitsakakis, Jeff Gao, and John Seymour are all part of the Think Rare team. And so we'll wrap things up there and leave it open to any questions that you may have. Our last message is we just want to put the faces of some of our children here who have received a diagnosis from Think Rare to keep in mind the impact that something like this can have for children being seen here at CHEO.
Thanks so much, Alex and Sarah and Ivan. I mean, it's really remarkable, and over a relatively short time period, what you've been able to achieve and to take an idea, the impact this has had on these patients and their families, but also the profile this has had nationally and now potentially internationally. It's really astounding, and really, this is I think the dream of all of us, to be able to have an idea, a research question, be able to incorporate, contemporary technology, and then move this into clinical practice. And to be able to do that in this time period is truly remarkable. So kudos to all of you and your team. There are over 130 people on the line, so I think that speaks to the interest across the organization, and we have lots of time for questions. Priyanka.
Hey there. Thank you so much for this great presentation. I have two questions. One is, does the patient have to have a PCP or primary care provider? Because I know I think I got a notification once, and then I was concerned because I wasn't the PCP and had seen a patient ages ago, but felt like they would be appropriate candidate. And I think I must have put a comment or something. So that was question number one. And question number two is I see newborns at the general, and I wondered if the algorithm would also work on mothers who have had antenatal ultrasounds, and we've noticed multi-system involvement.
Great questions. So I don't know who wants to take that,
Yeah,
or
I can probably field those. Yeah, so thanks. Yeah, really good questions. The first one is if you know that child, I can contact the family and ask about a genetics referral, then absolutely you can refer them to us. There's so many people without family doctors these days or pediatricians, and so still probably better to get a diagnosis, and then sometimes with a diagnosis, they're actually able to get a pediatrician because they're a higher needs family. So yeah, no problem with that referral.
Great.
This is looking at EPIC. So I would say prenatally, almost all patients with abnormalities in ultrasound are referred to genetics. So I
Okay.
don't think we're missing a lot there, but certainly if you see a baby who has been missed, you can, refer. If all those details are in EPIC, then yes, that'll get picked up. But if they're born somewhere else, it's not an EPIC, then well, I guess they are born somewhere else. So unless they're transferred over here to the NICU, that wouldn't they wouldn't be seen.
True. Yeah. Sometimes we have foreign families coming in with limited antenatal care, and in those circumstances, perhaps a genetic referral would help.
Mm-hmm.
Thank you.
great. And just while we're waiting for more questions, lots of positive comments in the chat, and we'll tell everyone in the audience that the evaluation link is also in the chat. So please click on that link to evaluate the grand rounds and for CME. Other questions?
I had a question. I work in the emergency department, and again, because many children don't have a primary care provider, I have found myself more than once referring patients to genetics, even though I've only met them for one encounter or for 15 or 20 minutes. Will those findings be flagged, like someone like that patient that Priyanka was mentioning, if they show up to the emergency department, will that be something that will be visible to all providers? Will that be visible to myself when I care for them?
Yes, it will be. We talked about that a little bit. We thought we'd mask it, and then I said, wait, I get referrals from you guys because no one else has seen the patient. So yeah, absolutely. You'll see those too.
Perfect. Amazing.
Hi, Jason. It's another Alex here, just lurching in predictably with a question. Great job, guys. Kim Boycott and I talked about this like 15 years ago, but you guys have just crushed it. It's amazing. Why can't we just go to Toronto and do this thing, Alex? I mean, basically, they have EPIC. We're in the same province, etc. Is it that big a hill to climb?
It actually boils down to the way that they have the naming system for their encounters as well as their lab side. So their genetics lab encounters, so their lab, the way that their labs are put in is much different than here at CHEO. So it basically takes away the ability to use one of our criteria.
Okay.
And the difference in Toronto as well is that a lot of the care is at different institutions in Toronto. So we still think that this is something that could function quite well, at sick kids, and we could make adjustments for it to work specifically for that institution. But even when we've met quite a bit with Alberta already, and each institution is going to have different different ways that they name things, different encounter types. And the way that the algorithm works, it would have to be adjusted to fit their exact specifications for encounter types and diagnosis codes, etc.
Okay.
Yeah.
I'm sorry. I'm almost sorry I asked. And the other thing, quickly, Ivan and I have had offline conversations about maybe extending this, in this case, to narcolepsy. And so whether or not variations on this theme can be done for specific subtypes of rare disease is another, I guess, possibility to look at. Although, once again, Ivan, not straightforward, but possibly valuable.
Yeah.
Anyway.
So a lot of the work in the space is actually targeting specific diseases, whereas our algorithm really just any rare disease. So yeah, absolutely, we can look at narcolepsy and other rare conditions. It's really about how well can we build a system that can identify these patients based on what's actually in their epic chart.
Yep. Thanks.
While we're waiting, I have a question and a comment. So, you highlighted the gratitude that these families felt for sort of resolving their diagnostic odyssey and making a diagnosis. I wonder whether, a bit of a provocative question, have any families or any providers had pushback because this is AI driven and sort of this feeling, whether it's a fear of AI or uncertainty about AI, that, it's going to lead them down a path that, may be inaccurate and lacking sort of in sort of the human component. I just wonder if that's come up through any providers or families that you've interacted with.
I can maybe start by answering that. So we see the patients once they've been referred to genetics, and we've certainly had a few families who wanted to meet with us first before they brought their child in, because they were probably surprised in some way that they were flagged. This had never crossed the family's mind. Although they were completely appropriate referrals, the family had never really seen a child as possibly having a rare disease or having questions that they had unanswered. So there's that for sure, but not part of the AI piece, though, didn't come up. It was more, I don't think my child really needs to go to genetics. Why do you want to see us there?
It's something you probably, encountered in genetics for,
Yeah,
many years, irrespective
right.
of the AI piece,
Yeah.
I don't know, Alex, have you encountered that at all when people find out that this is related to AI? I'm just, curious because the perceptions of AI out there, I get asked about this all the time, are varying.
I think the overall feedback that we've gotten has been actually really good. We haven't had any pushback from providers or patients about the use of this AI, and generally the AI that we're using is really very simple rule-based AI. It's not very, very complex. And, as Dr. Sawyer mentioned, we've had a couple of families where there's a little bit of pushback, more so as to why is my kid getting identified now, kind of what's changed. But the AI aspect, it actually hasn't been something that we've received much pushback on from anybody, whether it be at CHEO or the families.
Alex, maybe you want to
Right.
highlight that recent patient that actually had the article.
Yeah, interestingly, so I know that we had mentioned on one of our slides that there's been a lot of articles that have been published on CTV News and in other news institutions. And for the first time very recently, we actually had a patient that we saw in one of our ThinkRare clinics who came to us and said, I actually know all about you guys. When my family doctor got your letter, they told me about ThinkRare, and I was able to go and find the article on CTV News and read all about it. And this is so great. I'm so glad to hear that technology is being used to help us in this way. So the overall feedback has actually been really good, and it's been really, really interesting to see families look into this deeper and find these articles and really have a good understanding of how this is working to identify them.
Really happy to hear that. That's great. The comment I was going to make is that CHEO is hosting the Children's Healthcare Canada conference in Ottawa in April. And so I don't know if the ThinkRare group has been invited or submitted an abstract, but again, that would be a great platform where you'll have children's health leaders from across the country to be able to promote this. And if that hasn't, if you guys haven't submitted something yet, let me know, and through the RI or through Lindy's office, we'll see if we can get an opportunity to present there. Couple of comments in the chat, and I see Sarah, you responded to a question in the chat.
Mark
You
had a
want to
really
speak
good
about
comment. Yeah, so Mark asked, Dr. Zucker asked about whether or not we state specifically that the patient should be informed or asked. And like any referral, please talk to the patients ahead of time and make sure that they are on board. But I'm not actually sure if we state that directly here. We definitely say the family declined it. So I guess we sort of imply that you've talked to them and they've accepted it if you've ordered it, but we can make that more clear. In the
Yeah,
info.
we'll definitely add that.
Yeah, thanks.
Great. Thanks, Mark, for that comment.
Oh, false
question.
positive rate. So the false positive rate Okay. So the false positive rate, well, we've only had one patient so far flagged who didn't meet referral criteria, and that was because the chart was wrong. There was diagnoses in there that were not true. And so that's different from having a patient who we still suspect has a rare disease, but the detection rate of the test has been 70% in our hands. And it's 30% typically. So when we do testing, if we think a patient has a rare disease, even negative testing doesn't rule out having a rare disease in most cases. It just means we haven't solved it yet. Does that answer your question, Christina?
I'll
Yeah,
also
thank you
just
so much.
chime in to say, like, we're flagging about 5 to 15 patients a month, so it's not like a large amount of patients. It's very manageable downstream. And as we mentioned, the diagnostic solve rate is quite high for these, so we're happy that we're finding the right patients. But we also don't expect this best practice advisory to overwhelm the institution. It's really going to be, once again, 5 to 15 a month, which is very manageable for us.
Thanks, Evan. But Sarah, also your comment about that case that you mentioned, goes back to the slide that you showed around the importance of the quality of the data that's put in there, right? Like if there's inaccurate data that's put in, you're not going to be able, the algorithm is not going to, result in, in the right outcome.
Which is why if you get the BPA and you know this family really well and you're pretty sure it's not genetic, or you can explain multiple systems by a single system that just wasn't obvious to the algorithm, you don't have to refer. We definitely still want that level of expertise, the physician or resident to look at this and make sure it still makes sense.
Any other questions or comments? And of course, I would say that I'm sure Alex and Sarah and Ivan are happy for you to reach out with questions afterwards. And, if you try to make a referral as the BPA comes out and you have sort of questions about that, to reach out, especially if it's the first time you're trying to make the referral.
We've got Alex's extension and email right on the BPA there. So now you know who Alex is. Feel free to ask him all your questions.
Yeah, he doesn't sleep, so you can ask him anytime.
Anytime.
For the emerge patients coming in at 1 a.m., you can contact Alex.
Great. Well, I don't see any more questions. So thank you, all three of you, very, very much. Really exciting. And it is so wonderful to see this all come to fruition, and looking forward to the BPA being put into effect and continuing the referral rate and really helping these families. So thanks very much, everyone. Please complete the evaluation and have a wonderful day.
Thanks.